Imagine a hospital where every patient's risk of sudden deterioration is predicted not by intuition, but by a smart, data-driven system that learns from everything. Vital signs, lab results, medications, surgery schedules, ward census, even the subtlest shifts in clinical notes. This isn't science fiction. It's real, and it's already saving lives. Today, we dive deep into the Early Warning Index, EWI, a groundbreaking multimodal machine learning framework developed by researchers at MIT, UW-Madison, NYU, and Hartford HealthCare. This isn't just another predictive model. It's a holistic, explainable, human-in-the-loop system designed to detect patient deterioration before it happens, transforming how hospitals manage risk, allocate resources, and protect clinicians from burnout. Let's break it down. The problem: hospitals are overloaded, underprepared. In modern hospitals, clinicians are drowning in data. Vital signs, lab results, medication lists, surgical schedules, patient flow metrics. Each piece of information is critical, but integrating them into a coherent risk assessment. Nearly impossible. And yet, early detection of patient deterioration is everything. A delayed response can mean ICU admission, emergency intervention, or even death. But current systems, like the National Early Warning Score, NEWS, or EPIC's Deterioration Index, often rely on a narrow set of inputs. They're slow, inaccurate, and worse, they conflict with clinical judgment. Why? Because they don't account for the full picture. They miss the subtle signals: a scheduled surgery tomorrow, a sudden spike in ward census, or a medication change that signals recovery or decline. That's where EWI comes in. The solution: a multimodal, explainable, human-centered system. EWI is built on a simple but powerful idea: predict patient deterioration not from isolated data points, but from a unified, dynamic representation of all available information. It integrates 3 data modalities. 1. Tabular data: age, gender, medical history, social behaviors, e.g. alcohol use, administrative status. 2. Time series data: vital signs, BP, HR, SpO2, lab results, potassium, creatinine, trends over time. 3. Textual data: medications, diagnoses, clinical notes, processed using advanced language models. Here's the innovation. Instead of using traditional encoding methods like one-hot or top-K frequency, EWI uses a distilled version of ClinicalBERT, a medical-specific large language model, to convert categorical data, like drug names or ICD codes, into dense, meaningful embeddings. Why? Because rare but critical medications, say a high-dose vasopressor, can't be ignored. Traditional methods drop them due to sparsity. But LLMs understand context. They know that dopamine 10 mcg/min isn't just a label, it's a sign of hemodynamic instability. So EWI doesn't just see the data, it understands it. How it works: from data to decision. Every day at 11:59 p.m., EWI aggregates all data from a patient's stay up to that point. It computes a daily patient embedding, a single comprehensive vector that captures everything: clinical status, treatment history, ward load, and even future plans. Then it predicts the probability of a near-term deterioration event in the next 24 hours, defined as any of 3 outcomes. Emergency Response Team, RRTCA DART dispatch. ICU admission. Mortality. This is critical. EWI doesn't predict one outcome. It predicts the aggregated risk of any of these high-stakes events. That's more clinically relevant than isolated predictions. The model uses gradient-boosted trees, which outperformed both random forests and TabNet in testing. On a dataset of 18,633 patients across 110,900 patient admission days, EWI achieved a C-statistic of 0.798, a strong signal of predictive power. But here's where it gets even smarter. The human-in-the-loop, where AI meets clinical wisdom. No machine learning system should be deployed in healthcare without human oversight. EWI was designed with clinicians, not just for them. 2 key phases of human-in-the-loop integration. 1. Identifying corner cases. When the model made strange predictions, like flagging a patient with a DNR order as high risk, clinicians stepped in. They explained, this patient is not expected to be resuscitated. The model doesn't know that, so EWI was updated to respect end-of-life preferences. 2. Setting alert thresholds. Raw probabilities aren't actionable. So EWI stratifies patients into 3 risk tiers. Low risk, less or equal to 3% risk, no change or small increase. Medium risk, greater or equal to 3% risk, or plus 15% increase. High risk, 12% risk, or plus 6% increase. These thresholds weren't chosen by algorithms. They were negotiated with physicians, balancing sensitivity, catching real crises, and specificity, avoiding alert fatigue. After weeks of testing, the team settled on a 0.06 threshold for medium alerts and 0.12 for high alerts, optimized for real-world use. And when the model fails, it doesn't just fail silently. It explains why. Explainability, the power of SHAP. One of EWI's most powerful features is SHAP, Shapley Additive Explanations, a method that quantifies how each input feature contributes to the final prediction. For example, take a patient flagged as high risk. SHAP reveals, a scheduled surgery tomorrow increases risk because complications are possible. A DNR order reduces risk because the patient isn't being aggressively treated. A low RASS score, indicating sedation, increases risk, suggesting poor neurological status. High average heart rate, 105, is a strong predictor. Even ward census matters. A full ward means less individual attention, increasing risk. These insights aren't just academic. They're actionable. A nurse sees that ward congestion is driving risk and can advocate for resource reallocation. A physician sees that a medication change is improving the patient's status and adjusts care accordingly. This isn't just AI, it's collaborative intelligence. Real-world deployment, the dashboard that works. EWI isn't a research paper. It's live in a major U.S. hospital system. Every morning at 8 a.m., physicians receive a real-time dashboard with patient location, department, room, bed. Risk level, red, yellow, white. Risk trend, is the patient improving or worsening? Red alerts, high risk, trigger immediate review. Yellow alerts, medium risk, prompt closer monitoring. White alerts, low risk, allow staff to focus on higher priority cases. And here's the game changer. This system doesn't just predict risk, it helps manage flow. When a ward is full, EWI flags patients at risk before they crash. Hospitals can pre-allocate ICU beds, adjust staffing schedules, plan surgeries to avoid congestion, discharge low-risk patients earlier. This reduces bottlenecks, prevents overflow, and cuts readmission rates. The bigger picture, impact beyond the ICU. The benefits go far beyond clinical outcomes. Physician burnout is a crisis in healthcare. One reason: unpredictability. With EWI, physicians know who to see first. They can plan their rounds with confidence. No more guessing. No more panic. Resource allocation becomes data-driven. Instead of reacting to crises, hospitals anticipate them. Patient outcomes improve. Fewer ICU admissions, shorter stays, lower infection rates, and reduced mortality. Costs go down. Fewer emergency interventions, better bed turnover, and less waste. And the model is scalable. It's already being rolled out across 7 hospitals in the system, and future versions will support 6-hour or 8-hour updates to align with shift changes. Limitations and the road ahead. No system is perfect. EWI doesn't yet cover ICU patients, those already in crisis. It also doesn't yet include medical images or full clinical notes, partly due to delays in data availability and privacy concerns. But the team is already working on it. Future versions will incorporate radiology reports, nurse notes, real-time imaging data, once processing delays are solved. And the model isn't static. It's retrained every 6 months to adapt to changing patient populations and clinical practices. Final thoughts: the future of predictive healthcare. EWI is more than a machine learning model. It's a new paradigm, one where AI doesn't replace clinicians but empowers them. It proves that when we combine multimodal data, explainable AI, human expertise, and real-time operational feedback, we don't just predict deterioration, we prevent it. This is the future of healthcare, not just reactive medicine but proactive, intelligent, and human-centered care. If you're a clinician, a data scientist, or just someone who believes in smarter, safer healthcare, this is the kind of innovation we need. And if you're wondering how to get started, look at EWI's blueprint. Start with the data you have, respect the clinicians who use it, and build systems that explain themselves. Because in the end, the best AI isn't the most complex, it's the one that makes people better at their jobs. Thank you for watching. If you found this insightful, please like, share, and subscribe for more deep dives into the cutting edge of AI in healthcare. The future is not just automated, it's intelligent, explainable, and human. Until next time, stay curious, stay informed, stay ahead.